So David, very nice to see you here in London. We've had the pleasure of meeting with you in Lisbon, in Liverpool, and again now in London. It's the day after a very important speech given by the ex-president of the USA, President Jimmy Carter, at the House of Lords. It was a speech given in terms of the success behind the eradication of guinea worm led by the Carter Center. I know you're heavily involved in terms of that particular effort, and we just wanted to ask you as an initial question, it's had arguably, as you said, the most amount of success in any of the NTD disease eradication programs to date, from 3.5 million cases in 1986 all the way down to 22 cases reported last year, over a spread of 21 different countries in terms of geographies. One of the key things here for everyone in the community to look at is this is being done without therapeutic intervention, without drug intervention. What, in your opinion, would be the major drivers of success of this very successful program?
I think that the most important parameter is, first of all, the partnership established by the Carter Center with WHO, but in particular with endemic countries. Then there's the recognition that something very simple, like preventing people drinking contaminated water, would stop the transmission of this disease. The fact is that with guinea worm, during the International Water Decade of the 1980s, it was recognised that if the water decade was to succeed in its objectives, guinea worm could actually be a marker of success. Now, there is no drug, there is no vaccine, and there is no effective diagnostic unless the worms are emerging from a patient. And as you say, there are over 3 million cases in the 1980s. To get down to 22 cases in 2015 on the basis of very simple interventions which don't involve technology of people with white coats looking for something sophisticated is a remarkable public health effort and shows what can be done through partnership and getting across very simple health messages. And those messages and the strategies for the eradication program are very simple. Clean drinking water, i.e. provision of safe water sources, containing the cases that have been identified, preventing those cases contaminating water so that there's no longer any water fleas infected, educating the population to identify cases and report cases, provide filters for water, through the partnerships established by the Carter Center with organisations like DuPont and Westergaard, who provided water which would, filters which would effectively last a long time in tropical conditions, ensure that there's extensive health education and focus on endemic villages. And if those villages do have water sources that are potentially contaminated, treat them with abate, which is a safe insecticide or a copepod killer, and get those water sources treated as soon as possible after a case is identified. These are very simple measures. Allied to that, as the numbers of cases go down in endemic communities and indeed countries, provide a reward for reporting rumours and pay that reward if a case is identified as being a real case of guinea worm. So these are very simple measures, but countries have got to embrace it, and it's also about advocacy. And President Carter was in a unique position to contact presidents of endemic countries to push this program.
We hear often that there's a lack of governance in certain areas in terms of the endemic country, where you've got perhaps external political will, aid agencies, industrial partners, as you just mentioned, willing to go the extra mile and make the difference. And so it comes down to the governance and inadequate governance in certain areas. In this particular instance, how important, in your opinion, was the sovereign state healthcare cooperation in terms of mobilising the people, providing education? How important was that to the overall success of the programme?
I think you have to advocate for control of this disease through the impact it has on populations and on the not only the humanitarian impact but the impact in terms of agricultural development, preventing harvesting of crops, reducing the workforce, the adult male workforce in particular, when crops are due to be harvested. It's no coincidence that the word for guinea worm in Bambara in Mali is the disease of the empty granary, which expresses the situation where many farmers were unable to harvest the crops, which at the time of harvesting, because that was the time of peak transmission of guinea worm and the peak time emergence of guinea worm, which meant most of those communities, the adult males where transmission was high were severely disabled. And it was recognised by those communities as probably the most important condition, because you're talking here about issues around nutritional deficits and food security. And when you're dependent on annual rainfall and not irrigation, then you are at the mercy of the elements, and if you fail to harvest those crops, then you've got food insecurity for another year. So this was an issue not only of stopping a very painful disease, a disabling disease, but one which has an impact on issues around nutritional stress and food security.
If you look at the example of Mali as an example, as one of the examples, you've got in the Gao region in a proper violent breakdown in terms of societal breakdown that's happening. How is that, do you think, going to impact on the educational platforms or the awareness building? Or?
Where you have civil unrest, you undoubtedly have challenges in any disease eradication or elimination program. That is without dispute. Unless we have access to these areas, then we're going to have continuing difficulties, first of all, in making sure that there's adequate surveillance for the country programmes to determine the transmission has stopped. Because without access and quality surveillance in those areas, then WHO, through the International Commission, cannot be sure that we have stopped transmission. It doesn't matter whether it's Mali or Chad or wherever. The parallel for me is the problems that the polio eradication program is facing in countries like Pakistan and Syria, where the issue is access. And we know from the polio program's experience that health workers have been shot, they're deterred from immunising children. In the case of the Guinea Worm program, in the last 18 months, 3 people have been killed in various guinea worm activities in Niger and Sudan. So we're up against a problem.
We've just had the announcement just after, or literally this week, that DFID are putting forward £4.5 million towards this, continuing this effort. Do you think any of that 4.5 million will go into awareness generation of those communities that, this is
the 4.5 million that DFID is committed is part of the money which is required for what we best describe as the end game. We're down to 22 cases, human cases. The expectation is we'll go lower, but that is going to be driven by the continuing need to survey the last endemic villages, of which there are 20 in these countries. But we also have to ensure that in countries like Mali, we have access to the areas as well which have been subjected to civil unrest and where we know access is difficult. The same applies to Ethiopia, South Sudan, to a lesser extent Chad, where there are other problems related to a potential dog reservoir. I see each of these countries having different problems as we reach the end game. There's no question about that. In Mali, it will be about access. It will be about persuading the Tuareg populations, who are essentially very disinclined to engage with civil society, conventional government structures. And so getting health education messages to that sort of population who have never been historically associated with government structures is always difficult. And then there's the issue of accessing areas where, to be honest, the control of the area is not within the government's purvey. It is not possible to actually get into those areas for security reasons. Now, that has impact in terms of our ability, because WHO as a certifying agency is a UN agency. UN have strict rules about security and access in these areas, and that poses a problem downstream when we seek to certify the absence of transmission. Certifying the absence of transmission, be it polio, guinea worm, or whatever, is a significant issue because we have to prove a negative to the best of our ability. And that is never possible. We have to do it on the basis of the best available evidence, and that will be the government's ability to provide us with the documentation that says we have surveyed these areas. It's been 3 years since we last had a case, therefore we are submitting to you the evidence which convinces us that guinea worm transmission no longer occurs. As you say, 20 odd countries have already provided WHO with that evidence, and the Director General has told their Ministers of Health that WHO, through its commission, is satisfied that transmission has stopped, and it's been verified by an international certification team. That is a fundamental. We have to have that evidence for the remaining 4 endemic countries, but also countries which are in what we call pre-certification mode, who had last had a case a long time ago. Kenya is one, Sudan is the other, and the steps are in progress now to obtain that evidence that there's no longer any transmission of guinea worm in those countries. 2 other countries, Democratic Republic of Congo and Angola, we have no evidence that transmission has ever taken place there, but we need to have information which confirms to the Commission that transmission has never occurred and has never, during the time of the eradication programme since the 1980s, has occurred at all. So those are the steps we have to take in order to confirm that there is no longer any transmission. In support of this, the guinea worm eradication programme in Geneva is doing what the smallpox programme did, and that's to institute what's called a global reward for the detection of any human case of guinea worm. And that is projected to be launched in 2016 or 2017, and we are thinking in terms of a global reward of around $2,000 for anyone who reports to WHO or the country authorities initially a confirmed case of guinea worm.
What type of platforms do you anticipate that messaging is going to be placed on to drive awareness?
Well, it's a variety. It's television, it's radio slots, particularly radio slots in local languages. It's plays, it's very simple health education messages. In Burkina Faso, one of the classics for me in health education was every school exercise book was printed with front cover showing guinea worm transmission and making a very simple statement: don't drink dirty water, filter water to stop the transmission of guinea worm. Every child in every primary school in Burkina Faso saw that message every day in their notebooks. That raises awareness. It not only raises awareness amongst the children, but also in their families.
So from the measurement and evaluation perspective of these interventions, you mentioned quite a wide spectrum of behavioural intervention, radio plays, textbooks, messaging going out there to the endemic population. How much are the donor agencies that are involved in this as a stakeholder, how much are they looking to get a measurement and evaluation put into, assessing the impact of a particular programme?
I think that the donors are more interested in seeing the eradication of one disease. This is a multifaceted intervention. It isn't just health education. It's a combination of powerful interventions which we know work. We would never have got, in Nigeria's case, from 680,000 cases to 0 in 20 years if these interventions didn't work. And the interventions have got to be and have been supported in all endemic countries through significant advocacy. In Nigeria it was particularly the role of ex-President Yakubu Gowon, promoted by Jimmy Carter, that drove the Nigeria programme in the initial stages. But then the Ministry of Health recognised the importance of this. And I was privileged to be on the certification mission in Nigeria. And what one really detected when we completed our work and recommended to or said to the Minister of Health that we were going to recommend to the Commission that we were satisfied transmission of Guinea worm had stopped in Nigeria, an enormous pride in a public health achievement of a condition which was a serious impediment to agricultural development, was disabling, had impact on food security, as I've said earlier, on many people in the endemic communities in Nigeria. And the sense of pride that they'd achieved that, albeit with support and assistance from the Carter Centre, from UNICEF, from JICA and a range of other NGOs and bilateral donors, was enormous. And there was a significant pride in this, and rightly so. I mean, it is not an insignificant public health achievement, based on a fact that it's very simple interventionally, from clean water, containing cases, health education, reporting rumours, and maintaining a robust surveillance system.
I'm sure you've underplayed that in terms of the public health success of this particular programme. As we all know, it's only the second disease after smallpox to be eradicated. And I was just wondering, from a best practice perspective, given your leadership role in terms of the NTD effort at the Liverpool School of Tropical Medicine, what kind of best practice or lessons could be learnt and mapped onto other disease programmes, and how would Liverpool facilitate that?
Well, I don't think it's necessarily the role of one institution, that's the first thing to say. I think that I'm part of a community who have been interested in guinea worm and seen this programme evolve. I think that one should qualify the situation at the moment, because in any eradication programme, the end game is always the most difficult. We are down to 22 human cases, but in all eradication programmes, elimination programmes, there are problems, and those problems arise in the end game. And we have been surprised in recent years, for example, with the emergence of infections in dogs in Chad, something which was completely unanticipated. So my first remark is that the end game is a long one. We should not be surprised if there are surprises. We have to anticipate them. We also have to recognise that in the final process of and responsibility
which the Commission has to recommend to the Director General, when every country, as far as the Commission is concerned, has stopped transmission, we have to be 100% plus confident that we're going to be able to put our hands on the heart and say to the Director General, we recommend to you that you go to the World Health Assembly with representatives from every single government to say that this disease has gone from the planet forever. Because if we stop the transmission of guinea worm, we will have made guinea worm extinct. Now, the problems arise here as how can we be sure, for example, in settings like Chad, where we have the dog problem, or Mali, where we have difficulties of access, or Ethiopia, where we have a very remote, in terms of distance from central government and from local government, in a community which is on the border with Sudan and South Sudan, we have to be sure that surveillance is sufficiently strong, i.e. the health system itself is sufficiently strong to be able to report any detected case, and also have a functioning global reward system. These are critical factors because the Commission has a responsibility to say there is no more guinea worm in the world. And I think that's a tough call, and it's a significant responsibility. How long it will take to get there and what the cost will be, we don't know. The 4.5 million to which DFID has contributed will make a big difference, particularly in surveying the last remaining endemic villages, making sure that any case is contained within 24 hours, doesn't contaminate the water. That is the critical issue. But what we don't know is what the role of the dogs will be in the longer term. And that is one of my, let's say, concerns as we approach the last human cases, whether humans will be acquiring infection from those residual dog populations. And this is a big unknown.
So would you say that part of that surveillance is like a black box of things, elements within the surveillance? What would you say? Obviously, diagnostics is going to play a part. There might be technologies that would play a part in that. What would you say would be one of the most important structural changes needed on the ground?
I don't think we have proven that the simple approaches work. We have proven that the simple approaches work. We don't need any more technology. We need certainly to understand the dog epidemiology in Chad, but that doesn't involve technology. It involves surveillance, it involves understanding dog behaviour, it requires understanding that there may be a different transmission cycle with the parotenic hosts involving the fish. That is not technology. We are talking about simple public health measures and, critically, surveillance. And, if necessary, strengthening the health systems in the countries where it is more difficult than any other setting, because this is what it's about in the final analysis, getting to the places which are most difficult to access for different reasons.
I remember in Lisbon when we met a couple of years ago, you said something very profound, which a lot of people picked up on in the room. I certainly did, and that was, I'm going to quote it back to you, so you have to forgive me for that. But it's, you said people are sick because they're poor, and they're poor because they're sick. So, in essence, conditions of poverty which surround and confound and compound the whole NTD cycle, right? I wanted to ask you this, that in the countries that you've had success, the 17 out of 21 countries that you've had success, if you take these four out, the Chad and the Ethiopia, South Sudan and Mali out of the equation, you had success. Would you say the conditions of poverty have alleviated somewhat in those areas?
I think that certainly in general terms, yes. I think that you also got the four remaining endemic countries. you have to remember the success in those countries. I mean, the guinea worm was a really serious problem in South Sudan, and we're now down to I can't remember the precise number of cases, but less than 10. That is a remarkable achievement from several thousand infected villages. So even though we've not stopped transmission yet in South Sudan, it is going down and the public health problem is disappearing. Guinea worm, unlike the other NTDs, except for yours, is targeted for eradication. Yours isn't targeted for eradication as well. But this is driving the prevalence, driving the infection to as close to zero as we can get for the time being, before, as I say, the end game where you have to really intensify your activities and where this extra money is required. In the smallpox program was the same. I mean, if you have to look at the cost per unit case, and as you go towards eradication, the cost per unit case goes up enormously in comparison to what it was at the beginning. So this is what the donors have got to be prepared for, and the community, the guinea worm community, recognise it.
I mean, you've worked with and you know President Carter in terms of your involvement and the advisory involvement at the Carter Centre for many, many years. Coming back to his speech, would there be any important kind of take-homes for the global health community
I think
from that?
Yeah, I think that the take-home message for me was this is a long-term issue. Guinea worm is just one disease of a plethora of diseases which affect poor people. What Jimmy Carter articulated yesterday, for me, reflected the importance of advocacy and the importance of people, prominent people, to get engaged with diseases of the poor. The other factor was the fact that through his charisma and commitment, he's been able to persuade a very large number of donors to step on board. Not just DFID, but private sector, the Arab world in terms of supporting the Guinea Worm Programme, the industrial partners, people like DuPont and Vestergaard Fransen, in providing materials for filters. I mean, this has been a long-term commitment from his side, and then having the ability to access people of power and responsibility in countries. And because if somebody like Jimmy Carter comes to your country, he has access to the president. They respect him and what he's done, and they're prepared to listen to him. And he's advocating on behalf of the poor. And it's part of the Carter Centre's overall message in terms of its motto in relation to peace, human rights, equality, poverty alleviation. So I think that it's an exemplar of the way people who have left political power can leave a remarkable legacy.
Yeah. From a historical perspective, 36 years ago, or 30 odd years ago, in 1980, after President Carter lost the election because of the domestic election in the US, because of the Iranian hostage crisis, stepped forward 36 years, and now diplomatic ties with Iran and the rest of the world are normalising. It's quite an amazing closing of the circle, and we've entered into this post-MDG, SDG era. How much of an effect is that going to have in terms of some of the issues you've highlighted, pulling everyone together? And I'm really talking about the factors driving poverty in these areas.
As you rightly point out, in terms of the relations between the US and Iran as a measure of change, and the duration, for example, of the Guinea Worm Programme, which has basically started after his presidency, that's a very interesting comparator. I would say what a tragedy it's taken so long for the US and Iran to actually develop some kind of relationship. I mean, within their geographic spheres of influence, they are enormously important countries. And to have a political fracture of that size and dimension, which has essentially created many of the tensions that exist in the Middle East sphere at the moment, is for me a tragedy and perhaps should have been avoided. However, my concerns are that there are wide areas of Africa, from the Sahel to North Africa through to the Middle East to Pakistan, Afghanistan, through of course Syria, where some of the neglected diseases are really going to take off. I mean, the most obvious one are the problems of cutaneous leishmaniasis emerging in Syria, and the relationship between the activities of ISIL, the refugee camps, the impact of disturbance and civil destruction of civil infrastructure on sandfly populations, is creating epidemics of cutaneous leishmaniasis, and we've seen this before in Afghanistan. One of the features of refugee camps in Afghanistan was the proliferation of cutaneous leishmaniasis. That's a neglected disease. There's very little that can be done about it. It causes gross and lifelong stigma through the lesions, particularly on the faces of children, something which is entirely avoidable and tragic. In the context of what we were talking about in terms of access, there are large areas where the UN will not permit access through this region, and therefore the problems in relation to, let's say, drug delivery on the one hand, or accessing populations to verify the absence of guinea worm transmission, are going to be a major problem, and I think we need to face up to that. There are obviously areas where we've had remarkable successes over the last 15 years or so with the NTD programs and preventive chemotherapy, but the final analysis is these programs are programs which the governments should actually embrace. We have, in the context of preventive chemotherapy, free drugs, essential medicines, all of them, valued at literally several $1 billion worth of drug per year. If the countries do not take those drugs up and they have access to them, then I think that's tragic for their populations, because otherwise the governments themselves would have to pay for these products. They're quality products, there's no counterfeiting in there, we know they work, and there is an entitlement to basic medicines, and their proportion of national health expenditure which is required simply to deliver these free products is between 1% and 3%, even in the poorest countries. So we need to make sure that ministers of health, senior officials in health departments are aware of this remarkable drug donation program to which they are being encouraged to access. And we hear from companies like we hear from companies like GlaxoSmithKline that those drugs are not being accessed in the volumes which we had expected them to be. And the problem may lie in the fact that after a while, the current 10 or so pharmaceutical companies who are providing free drugs will say, well, why are we making this offer? Certainly as part of our corporate social responsibility role, when the countries themselves aren't taking them up.
And are you involved in any initiatives at Liverpool? From the Liverpool perspective, I know you've got things like Countdown NTDs and various other groups and initiatives. Are there any specific initiatives centred around this?
Not particularly, no. I mean, I think that the totality, I don't think it's particularly an institutional issue. I think it's a policy issue at the highest levels of the World Health Organization in particular. I think that what Margaret Chan has done with NTDs has been really remarkable in drawing the attention of ministers of health to the issues of NTDs and linking it to universal health coverage, in the sense that here we have populations that deserve access to quality products as part of the national responsibility to provide healthcare to their citizens. You cannot do more than say, here are free drugs. For me, that is a remarkable gesture. We've got to try and persuade countries, together with donors and many NGOs who are involved, that we will provide at least some assistance. But if you want to do it, please find the resources, albeit small, to deliver those drugs that you would otherwise have to pay for and which communities, individuals are entitled. And I feel quite strongly about that. And the message has got to come from the World Health Organization, in my view, because it's there that the countries convene every year at the World Health Assembly. We now have a resolution which was done and agreed in 2013, the World Health Assembly Resolution 6612. That lays the template for the strategies for NTD control in relation to the WHO roadmap, which all the partners in this community have signed up to. If the countries don't access the drugs which have been made available to address the technical and epidemiological issues of these diseases, then I don't know what we in Liverpool or London or Imperial College can do. We have got the partnerships there which are able to advocate for all the diseases in the NTD portfolio. We have the disease-specific partnerships which are highlighting the particular successes, be it river blindness or filariasis or schisto or whatever, trachoma in particular. I mean, these are remarkable communities committed to delivering these drugs, and we want to do it. But, you know, you can, the expression is, you can take a horse to water, but you can't necessarily make it drink. And I think there's an analogy there. I think the other issue is that we do have problems, and this is one of the things that I'm involved with, we have problems in local capacity. If there's no capacity, you can't do anything, and that capacity is related to understanding what NTDs are, how you implement NTD programs, and that is not only at the national level in terms of providing the resources for national managers for NTDs, but also going down to the districts where many of these programs are implemented and resourced, and to see how district level managers handle the drugs that come in, how they monitor and evaluate within their own settings.
So there's also a very interesting juxtaposition in terms of you've got the most successful eradication program done without the use of therapeutic intervention drugs. You know, your Guinea Worm effort, you've been wholeheartedly involved in that for many years. And then there's this juxtaposition now with the current situation with Ebola as an example, and also now very topically with Zika, in that there seems to be an immediate rush towards therapy. So with Ebola, it was straight to the ZMAP, or in the case of Zika now, we've already had announcements this week, in fact, from Sanofi that they're going to be using their dengue vaccine engineering platform to look at Zika in terms of a vaccine candidate. And yet the most success has come from a program without any drug. And I just wanted to get your opinion on that.
One of the great things about Guinea worm in terms of an eradication target is its reproductive capacity may be significant in terms of its R0, but the issue is that it takes a very long time for the worm to develop and evolve. A virus transmitted by a mosquito is a very fast-moving creature, and you're dealing with insect populations like Aedes that are highly adaptable, exceedingly difficult to control. And we really have no knowledge that I'm aware of the fundamental biology of Zika virus in Aedes aegypti, and certainly not in Aedes albopictus. We have no idea of whether Aedes albopictus is a potential vector. If it is, it has significantly increased threat to the more subtropical parts of the world, and possibly southern Europe and southern states in particular. So here we have, I mean, 2 weeks ago we had no knowledge of Zika virus. It was an exotic virus, and suddenly we get this association with clusters of microcephaly, but it's still not a proven association. That point was made. It doesn't mean to say that is not a global public health emergency as expressed by the International Committee on Monday, but there are certain fundamentals of the biology that we need to understand. And I think for me, one of the most important is the relationship between Zika virus and the mosquito, because the driver of this is the mosquito. The tragic consequences of the potential sequelae from Zika virus will require a much longer time to understand, because the epidemiology and the population sizes that we're going to require looking at are pretty extensive. How long it will take using the dengue platform to develop an effective develop an effective vaccine, who knows? I mean, you know, we've been looking for vaccines from AIDS, HIV, for malaria, indeed dengue, for a very long time. Now my knowledge of viral immunology and vaccinology is very limited, so I wouldn't like to express an opinion there. But the question then is, if there was an effective vaccine, if there was an effective vaccine, who would pay for it? Who would be the primary targets for delivery? What is its efficacy? What are the risks in terms of, for example, would you vaccinate pregnant women? Would you vaccinate all women of childbearing age, adolescents, etc.? So, I mean, there's so many questions out there. The one thing I would say is that if we're to do what I think is important in terms of control of the potential spread of the mosquito, we have to be aware that just spraying or fogging mosquito populations in urban centres in the Americas has to be looked upon with a certain amount of caution, because just spraying is like shutting the stable door after the horse has bolted. Transmission has occurred, particularly to those women who are potentially those at greatest risk. If you're talking about stopping further transmission, then a whole set of other parameters come in, because vector control is not a simple approach. Just spraying, particularly fogging in daylight, is not going to be effective. Ultra low volume spraying, which is what fogging is, requires a significant amount of technical expertise in relation to when you spray, what you spray, how frequently you spray. Because if you're to make a significant impact on mosquitoes, it's got to be done over a period of time. Killing the existing adult mosquito populations and then spraying again before the mosquitoes that have emerged from the larvae, which would not be killed by the spray, reach a stage when they might transmit Zika virus. So you have to partition your spraying into cycles which relate to the biology of the larval and pupal stages of the vector. So this is not a simple activity, and the authorities who are responsible for vector control have to take that on board, in addition to, if they're going to use larviciding measures, knowing where the mosquito sites are. What concerns me is that people have been talking about spraying or putting insecticide into stagnant water. Aedes aegypti never breeds in stagnant water. It breeds in clean water, and if there's organic content in the water, it does not lay its eggs there. So you really have to be cautious. about your approach to the entomological and vector control aspects of this condition. It doesn't matter whether it's Zika or yellow fever or dengue or whatever, or chikungunya. These mosquitoes require a significant amount of technical knowledge, and what I haven't mentioned either in this is what are the insecticide resistance maps of Aedes vectors in the Americas? Do we know the susceptibility of Aedes to the different insecticides that might be used? I think the answer is we don't.
And is that an area you'd like to see more research done in, and you think?
I think the research could be done very quickly on this. I mean, the Liverpool School has got the largest concentration of vector biologists who know about these things than anywhere else. Our resources should be used and could be put into effect very rapidly because we've got all the technology to detect the genetics of insecticide resistance. It's a question of deploying them. Then it's a question of getting the right insecticides in the right place at the right time and using them appropriately. There's no point in spraying, well, fogging in the middle of the day.
Could we be as bold as to say that's almost a call for partnerships in terms of at least the mapping from Liverpool's perspective?
Well, I mean, we have the Integrated Vector Control Consortium based in Liverpool, which is the biggest vector control consortium based on a series of partnerships with the United Nations, WHO, the private sector, the pesticide industry. So we're already geared to the partnership side of this. That's not the problem. It's the problem of the perhaps resources, but deploying those resources in the appropriate way to address the specific problems identified if you're going to use vector control for the control of the Zika virus.
And so staying on Zika virus for a second, but coming out of the technical aspects a little bit, so the vector control aspects that you've mentioned, in your opinion, what's driving the disproportionate public awareness of Zika, Ebola, the coverage that these two diseases in particular have seemed to have received?
In one word, fear. Something which is difficult to define, unknown, affecting essentially poor populations in very remote areas, highly infectious virus. Will it come to UK? The focus in the tabloid press is what are the risks of transmission? Does Aedes occur in Britain? Will it occur in Britain? Are we under threat? It's the old fear factor, I'm afraid. Resources were only mobilised for Ebola to a significant extent when somebody died in Texas or a nurse became infected and ended up in Madrid. Then the fear factor became significant and countries thought, well, we better do something about it. Ebola was detected many years ago and identified by Professor Piot, who is now the director of the London School. And it lingers in Central Africa with the suspected reservoir in bats. It's not surprising that these viruses emerge. 70 to 80% of human infectious agents are derived from animal sources. So expect more. We don't know where Zika has come from. It was allegedly from monkeys in Uganda in the 1940s, 50s. Possibly. It may have come from other in the Americas. Do we know if it came out of monkeys in the Americas? Because you have yellow fever in the primates in South America. Those are unknowns. We have to deal with what we've got. Ebola killed 12,000 people according to WHO. Absolutely tragic, highly infective, and that was another fear factor. Contaminated people go down very quickly, well, not very quickly, but over a period of 30 days incubation period. And that was one of the problems with Ebola. You have a highly infectious virus but a long incubation period, or potentially a long incubation period, which means that people can be infected for longer. But I take the 12,000 deaths. The numbers of NTD deaths. According to the Global Burden of Disease study in 2012, was there were 150,000 NTD deaths in a year. So NTDs killed, and I think it's an inappropriate estimate, I think at least twice as many NTD deaths as the 150,000 attributed by the Global Burden of Disease study, nearer 300,000. But even if we take that number, it's still 10 times more than the numbers of people who died of Ebola. So I think we need to get these things in perspective. I'm not saying we shouldn't do things about threats like Ebola, but those emerging threats have always been there and will always be there. Just think in terms of the epidemics of plague that spread through Asia and Europe during the Middle Ages and into the 17th century. And the same with syphilis during the wars of the Napoleonic Wars and the subsequent wars in Europe. These are not new phenomena. We're more aware, there's more globalization, there's more rapid climate change, there's more rapid environmental change, agricultural change, change in water resources and water reservoir levels, etc. And these are all going to provoke and intensify the potential of disease.
Are NTDs occupying the centre ground in the SDG framework? And by that we mean, are they becoming the absolute measure or benchmark measure for...
I would say that NTDs as a group should be the key measure of success of the health parameters, or some of the health parameters of the SDGs. Why? Well, because they affect 1 billion plus people. So you've got a much greater spectrum of people infected than you would have just with HIV, or just with TB, or just with malaria. Geographically, population-wise, numbers of infected countries. So that's one issue. The other issue is this, that individuals are infected very often with many more than one individual NTD infection. So you have, we call polyparasitism, comorbidity, co-infection, whatever you want to call it. So addressing the NTDs is actually a broad measure of access, ability to measure the impact, because we have good measuring tools for all NTDs, and we have a community of partners focused down on this target of making sure that 90% of the people who require interventions from NTDs get it by 2030. And I think that if we can achieve that, we'll also achieve elimination, possibly permanent elimination of transmission of many infections, and certainly the end of significant morbidity in many of these conditions.
Okay, so you mentioned, obviously the comorbidity and the co-infected reality in terms of polyparasitic infections being the kind of reality that people need to understand and accept and work around and on in terms of the infected populations. We're obviously delighted that you're going to be coming to speak from a comorbidity perspective at our co-infections and community conference on the 29th of April here in London. Would you like to just elaborate a little bit for the viewers in terms of what you're going to be speaking about?
Yeah, I mean, I've been aware over the last few years that many of these infections, the NTDs, are responsible for significant disability, stigma, marginalisation of individuals because of the deformities they cause, the lesions they cause, and the impact of those lesions on the social and economic environment of individuals and families. And in thinking about this, and we have evidence from the literature for diseases like leprosy, lymphatic filariasis, behavioural, that there is a significant amount of mental illness, and particularly depressive illness, associated with these conditions. We've done some work recently in quantifying that in lymphatic filariasis using fairly conservative estimates of the amount of mental health disability associated with filariasis, as an example. And our studies indicate very clearly that in comparison with the Global Burden of Disease study, which allocated something of the order of $2.6 million to filariasis, our calculations show that the mental health disability of lymphatic filariasis is probably 2 to 3 times that. That does not take into account, and the issue which I think is really important here, is that if you're disabled, if you're particularly blind, you require the assistance of caregivers. A caregiver could be a child or it could be a parent, but that caregiver also therefore suffers consequences for mental health. And it also means that the children, or the parents of the children, are therefore unable to access education or afford access to education for their children. So we have a whole sequelae of events associated with a condition of an individual which has impact on the family and the community, and as a result of that on the educational prospects. And I think this is a completely under-researched and under-quantified area of NTDs. And it applies in particular to diseases where you have obvious stigma. Skin diseases, in particular onchocerciasis, cutaneous leishmaniasis, behavioural, and then we have the disabling diseases such as lymphatic filariasis, where you have genital lesions, you have elephantiasis, of course you have podocarditis as well, where there have been some excellent studies on the mental health front there. So I think this is a really important issue. Added to that, so many people are infected with these conditions, and that mental health burden should be added to the mental health burden which is already recognised by the global health community. If you look at the global mental health literature and the calculations in that literature, there is no mention anywhere of neglected tropical diseases. But if you look at the criteria of what WHO recognises as conditions associated with mental health, those conditions mimic precisely the situation you see in neglected tropical diseases. Issues of stigma, physical abuse, sexual abuse, inability to access learning, inability to access healthcare services, inability to marry, inability to access education. Those are conditions which are absolutely common between NTDs and mental health.
Well, I think it's an excellent example of how, and we're all seeing this echoed across quite a few research groups, but you've articulated that very, very well in terms of, very powerfully actually, in terms of how the NTD SDGs and the SDGs related to entities are gaining centre ground in terms of being the measurable against which all the other SDGs could effectively be benchmarked and measured in terms of impact. And we'll be certainly looking forward to your speech, presentation and involvement at our 29th of April event. So we'd just like to say thank you very, very much for making time to come and speak with us. It's been an absolute pleasure and an honour, and we look forward to meeting again, and thank you.
My pleasure, and I just hope we continue to make an impact promoting the cause of these diseases which afflict so many people, but more importantly perhaps diseases where you can actually do something, and whatever we do will be on a permanent basis and relieve generations of the stigma of these infections, which have for so long been not only neglected but totally ignored by the global health community, reflecting the fact that if only 0.6% of official development assistance resources are spent on diseases of 1 billion people, there is a degree of inequity which for me is politically unacceptable, and we have to go some way to changing that particular figure and increase the amount that we need. I mean, the reality is we need an additional $200 to $300 million per year to deliver free drugs to poor people. That is not a large amount of money in comparison with the spend on other health issues which affect fewer people in comparison with these diseases, where we know we can make an impact. History has shown that these diseases are eliminable and at a very limited cost, and the economic rates of return are remarkable, and the savings that can accrue to poor populations equally so.
I think it all comes back down to your profound quote, people are sick because they're poor and poor because they're sick. So again, thank you very, very much.
My
and
pleasure.
look forward to seeing you again. Thanks a lot.
Thank you.